Hello, and welcome to the Georgia Prostate Cancer Disparity Rally Town Hall meeting. I am Thomas Farrington, the president and founder of PHEN. And I want to thank the audience for tuning in today, and I want to thank our sponsors that you may have seen them as our curtains were being drawn back. The town hall meeting today is a culmination of the Georgia Prostate Cancer Disparity Rally that PHEN launched at the beginning of May. This included radio and social media awareness campaigns focused on Atlanta, Augusta, and Savannah. Our goal was to reach 750,000 to 1 million people by radio and social media. We were pleased to have 16 leaders and patients who participated in this campaign. These leaders included doctors, community leaders, clergy, political leaders, and patients. And I want to acknowledge and thank each of them for their support. It was exciting to have these leaders join with us for this campaign. In fact, to mobilize these leaders to speak out to address the prostate cancer racial disparity was one of the major objectives of our rally. So we feel very good with this accomplishment. A little background. PHEN was founded in 2003 with a mission to eliminate the prostate cancer racial disparity. We focus our national efforts on cities and states with large Black population where there are large prostate cancer disparity. The Georgia rally is our 7th state, including the District of Columbia, where we've held the rally beginning in last year, 2021. Our town hall meeting today brings together some of the leaders that have joined us for the rally to discuss key factors that contribute to the prostate cancer disparity, collaborative efforts that can be undertaken collectively to address the disparity. I am going to introduce these leaders, then introduce Adrian Backus and Dr. Crawford to provide some more background information to give us a pretty clear perspective of where we are and where we hope to go. We would then begin our discussion. The audience will have the opportunity to present questions at any time. You can type your questions into the Q&A box, but we will provide answers after the panel discussion. Again, you're certainly welcome to input your question, and we will hold it until after the panel discussion. So at this time, I want to introduce our panelists for this evening. First one is Bishop Thomas Brown, Sr. He's a presiding prelate of the CME 6th District, and he's also a prostate cancer survivor. Welcome, Dr. Brown, Bishop Brown. We have Dr. Millard Collier with the Family Medicine at Atlanta West Primary Care Associates. And Dr. Collier has worked with PHEN on some of our initiatives in Atlanta before. So it's good to have you with us again, Dr. Collier. Dr. Ashante Estelle, who will be joining us, coming back to Atlanta. She graduated from Morehouse Medical, and now she's at the University of Wisconsin, but she's coming back to be part of the Emory Urology Department. However, she's not going to be with us. She informed us that something had come up. Mr. Milton Little, Jr., who's the president and CEO of United Way Atlanta. Milton is someone that I've known for many years, a good friend, and he's also a prostate cancer survivor. Mr. Keith Milner, the chairman of the board of the 100 Black Men of Atlanta. And Keith, welcome. Reverend Dr. Kevin Muriel, the senior pastor at Cascade United Methodist Church. Welcome, Reverend Muriel. Mr. Harold Oglesby, the president of 100 Black Men of Savannah. And welcome, Mr. Oglesby. Dr. Thomas Shook, a urologist. He's also a member of the Urological Association of Savannah. Dr. Shook, welcome again. And we have Dr. D. Ron Spearman, who's a survivor and retired primary care physician. Dr. Spearman, we welcome you again. And we have Dr. Martha K. Terrace, who's a chair in urology at Augusta University. So these are our esteemed panelists for this evening. And as you can see, we have a good, diverse panel. We wanted to get different perspective on how we address the prostate cancer disparity. And so again, we're so excited to have each of them with us today. Now, there were others who participated in our disparity in our prostate cancer rally by recording messages that are not with us this evening, but we thank them as well. We had Reverend Dr. Gregory Eason, Reverend Augusta H. Hall Jr., Mr. Grant Hill, Mr. Bill Light, Representative Billy Mitchell, Mr. Glenn Pate, and Dr. Martin G. Sander. So again, we brought together, as I said, this is one of our major objectives, was pull together leaders that will be willing to speak out in the fight against prostate cancer. So I thank them each, and we're glad to have the ones with us on the panel this evening. So at this time, I am going to introduce Adrian Backus. Adrian is our Director of Community Outreach and Partnerships. So I'm turning it over to you, Adrian.
Thank you, Thomas, and good evening, everyone. Historically, PHEN has spent more than a decade providing educational awareness and support to save lives relative to the prostate cancer disease within the African-American community in the state of Georgia. Let's see where my screens are there. And such longstanding support has included recruitment of prostate cancer survivors to join the PHEN Survivor Network. Beginning in 2009, over 22 churches of all denominations across Georgia joined PHEN's annual Father's Day rally, which is held in the month of June. And PHEN hosted the nationally acclaimed Daddy's Boy stage play at the Riverside Epic Center in Atlanta, another very successful effort to creatively entertain the public about prostate cancer. The recently launched PHEN Prostate Cancer Disparity Rally effort builds on this long-term, historically firm foundation of prostate cancer support with the continued obligation, we want you to know that, and commitment with the following objectives. One would be to build and expand PHEN Georgia partnerships. Second, to raise awareness similar to the recent month-long launch social media and radio communications campaign, which utilized the voices of community leaders and survivors of the state of Georgia, some of whom you will hear from tonight. And we hope to continue to support efforts which encourage and provide early detection screening, provide PHEN online educational resources and critical information on treatments and clinical trials. And we hope to provide ongoing initiatives and partnering relationships for PHEN and Georgia citizens for decades to come. As PHEN Director of Community Outreach and Partnerships, I unabashedly thank you all for being a part of this PHEN Georgia Prostate Cancer Town Hall Coalition tonight, which dare ventures to speak out, to save lives, and we thank you. Have a good evening.
Thank you, Adrian. Thank you. I also want to add a little something to what Adrian showed you. One thing we did have, it was on the screen, and I just want to highlight this. At Ben Hill United Methodist Church, we held 4 or 5 education symposiums over the years. And so those were good programs that were invited, not just for the Ben Hill members, but for the Georgia, Atlanta community. The other thing is that I am a 22-year prostate cancer survivor. And actually my prostate cancer journey and the foundation and the whole vision for PHEN really came about in Georgia. And that's because I was treated in Georgia, from Boston, to Georgia at the radiotherapy clinics of Georgia. And so that was 22 years ago. And during that time, I realized in talking to other men that we did not have the knowledge that we needed to have to successfully face and beat prostate cancer. And so I wrote a book called Battling the Killer Within. And from this book, I began my whole journey of speaking out and outreach, which led to the founding of PHEN. So I have a special place in my heart for Georgia and all of my good friends in Georgia. So at this time, I want to introduce Dr. Keith Crawford, and Dr. Crawford is going to give us some perspective on the statistic, the prostate cancer statistic nationally and specifically in Georgia. So Dr. Crawford.
Hello, everyone, and thank you again for joining us. And we have a very exciting event this evening. I wanted to take the time, put up my slides, to go over the statistics as it relates to prostate cancer. So what's important when we start talking about statistics is where does your data come from and how do you apply your statistics? So this talk this afternoon, the data that I'm going to give you comes from the National Cancer Institute, and we're using the state cancer profile. We're also getting data from the SEERS, or Surveillance Epidemiology in Results program, from their database. So first, when you hear statistics or information about the incidence or mortality related to prostate cancer, you may hear it from the American Cancer Society. Now, when you're hearing statistics that reflect the year that you're in, then what you'll find is that those do not represent hard data. They represent estimates that have been based upon an algorithm designed to predict what the incidence will be. Your hard data takes about 4 years to catch up to the year. So if you hear numbers in 2022, it won't be until 2026 before you know if those predictions were accurate. So here, across the top, I'm going to focus.
Keith,
Yes.
I'm sorry. You need to share your slides.
Oh, 1 second. I think that that's better. Okay, so everyone can see that now. So when we're talking about statistics or estimates, these estimates come from the American Cancer Society. And across the top of my table, you'll see the estimates for 2019, 2020, 2021, and 2022. And then we'll give you increased numbers, the increase over that 4-year period and a % increase. Now, the top cancers that we're going to focus on are prostate, breast, lung and bronchus, and colon rectal. The most important thing to take away from this table is this: that between 2019 and 2022, the American Cancer Society estimates an increase in prostate cancer cases upwards to 54%. Now, this can be explained because they said that there was a change in their algorithm. But the point here is we're alerting everyone of this crisis that exists when it comes to prostate cancer at a national level. Now, if you compare prostate cancer with breast, lung bronchus, colorectal, you'll see that there are marginal increases, but none of their increases exceed 4% over a 4-year period. Next. Let's look at this at a local level, at a state level, because the information that I just provided you was a collection of the data out of 50 states. But let's just focus on Georgia and look at prostate cancer incidence and deaths. For every 100,000 Black men, there are 194 cases that were reported. Now, if you compare that to white men in Georgia, there were 109 cases reported per 100,000. Now, for Black men, that's 77% higher rate of new cases or cases when compared to the majority population or to Caucasians. Now, if we look at the rate of deaths, you'll see that compared to white men, Black men die at more than 2.5 times greater risk. And that's for the state of Georgia. Now, let's just compare what's happening at a national level. And even when you look at it at a national level, the incidence of cases, now these are cases that are hard cases that were reported and documented in 2018, that the Black men in the state of Georgia still exceed Black men nationally as it relates to deaths at 41 deaths per 100,000 to 37 per 100,000. And even from the standpoint of comparing Black men at a national level to white men, Black men from Georgia and white men from a national level, you'll see that the incidence is even much higher. Now, one thing Georgia's doing a better rate of treating white men than at a national level. But the most important thing that we want to take away from this slide is this: prostate cancer racial disparity is the largest racial disparity in Georgia and in the United States for men and women. Again, we always say that politics is local, then we're talking about prostate cancer information is also local. Now, if we dig down and focus on our target cities that are found in Fulton, Richmond, or Chatham, you'll see that the incidence of prostate cancer in 2018 was 194 cases per 100,000 Black men compared to 111 or 118 cases for white men in Fulton County. Now, the difference there is about 64% higher than that of white men. Now, this is lower than what was predicted for the state as a whole. Now, Augusta or Richmond County, and our target city is Augusta, we'll see that the rate in Richmond area is 186, 187 Black men per 100,000 cases per 100,000, compared to 98.5 cases per 100,000 for white men. Notice the disparity increases up to 90%. And if we look at Savannah and Chatham, the number of cases per 100,000 Black men reaches 200. And this is 100% higher rate than what you'll find over white men. Now, the point here is that if you look at all the counties, and so if we look at move to the graph of the state of Georgia, now these areas demarcates all the counties that are in Georgia. Now, the high intensity is red, and next to red would be the orange. Next to orange would be the light blue, and the dark blue represents the lowest level. So Fulton County here, Richmond County here, and Chatham County here. Now, the take-home message is this: there are differences in the incidence and mortality rates in Georgia in different counties, to a point that there's 26% of the counties that reported information about prostate cancer in relationship to Black men were above 200 cases per 100,000 men. Georgia's prostate cancer crisis. The American Cancer Society ranks Georgia as the 9th highest state for prostate cancer new cases and deaths in 2022. In Georgia, Black men have an overall 77% higher incidence rate and 2.5 times greater death rate than white men. Prostate cancer racial disparity is the largest racial disparity, and I'll say it again, is the largest racial disparity in Georgia and in the United States for men and women. And it's important to understand the statistics and the population of people in Georgia. The United States 2020 Census reports that the population of Georgia is around 10.5 million, of which 31.9%, close to 2% of that population is Black and 52% white. So there is a crisis that exists. So what are we going to do about it? Thank you.
Thank you, Dr. Crawford, and also thank you, Adrian. What we want to do now is to really discuss, first of all, what is driving? What are the key factors driving the high prostate cancer disparity in Georgia? And I'd love to get the panelists comment on that, and whoever would love to begin that discussion, the floor is open to you. Now, I know that if you look at some of the factors that are well known, and I just want to throw this out, that with early detection, the 10-year survival rate is 90% plus. With late stage detection of prostate cancer, the 10-year survival rate is about 35%. That is a big, big difference between early detection and late stage detection. So certainly that is one of the major factors that drives the disparity, and it would drive the death rate for whomever. But you know, if we look at some of the screening rates across the country, we do know that Black men screening rates are not where they should be. And I've often said that to compare screening rates for Black men to white men, they should not be 1 for 1. If they're equal, that's still not good enough because of our higher risk. We need to be more aggressive in screening. Who would like to discuss that point?
Well, I can offer a few thoughts about that. Okay. The bulk of my practice career was as a general internist, practicing at a primary care level. And of course, as an internist, geriatrics was a significant component of my practice, in that I followed a significant number of patients, for many decades. And I think that one of the things that Mr. Farrington mentioned that really rings true to me has to do with just the lack of awareness of the significance of early detection. I think that all too often patients present when they have had symptoms of advanced prostate cancer, which very predictably increases the morbidity and mortality. Whereas patients who are screened early on and or diagnosed early with, in particular now with all of the effective treatment modalities that are available, I think would do considerably better. And I can just reflect over my career when, as a student and as house officer, the tests or the parameters that we used at that time were probably not much better than detecting advanced disease. Whereas now, with the advent of the PSA, that gives us certainly a tremendous opportunity for early detection. And I have, in my own practice, I've seen things improve a lot in that little microcosm where we were doing early detections. I can recall maybe 20 years ago when I was seeing cases in patients who were less than 50, which was certainly in a stark contrast to what I experienced, what I was taught, what I experienced in training. We began to gradually decrease the age in which we would initiate screening. And I guess maybe about 20 years ago, in my own practice, in African-American men, I initiated screening at age 40. And the very first patient that I examined at age 40 had a PSA that was disproportionately high for his age, about 3.6, I think, which is below the upper limit of normal, but adjusted for age, that certainly raised suspicion. And this person actually was referred and ultimately was found to actually have actionable prostate cancer at the time. And he opted for radiation, but he's done very well, and for 20 years hence. So I think that my concept is that we need to dwell on the irony of the fact that while prostate cancer in African American men has a very high level of high incidence and high morbidity and mortality, the irony is that if it's with early detection, it's also one of the most eminently curable and treatable treatable cancers. And so that's been my thrust in my active career and in my retirement career of just emphasizing the importance and significance of early screening. I think we've done comparatively a better job with women in terms of expounding on the significance of mammograms. I think that while that's not perfect, I think that concept is ingrained a little more thoroughly than PSAs and a urologic examination of men. So I think that's and hopefully this is something that PHEN will accomplish. But I think that's really the key of just getting the awareness out there.
Thank you, Dr. Spearman. Dr. Terrace, I think you had something to add to say.
Yeah, thanks. Of course, your original question, why is there a disparity in the severity of the disease and the young age at which it occurs, is one we don't have a good answer to. We know there are certain genetic dispositions that hormonal cancers, such as breast cancer in women and prostate cancer in men, tend to be more severe and occur at earlier age in Black individuals. The question that we've been asking, well, does the same thing happen in Africa, for example? And unfortunately, the medical care there is not of a quality that we can really track that as well. Is it something really genetic that happens to all people with dark skin? Or is it something to do with a combination of dark skin and then growing up with an American diet, with the high-fat junk food diet that we have? Is there some perfect storm of factors? So the why is a mystery. But Dr. Spearman was exactly right. The way to approach it kind of doesn't matter what the why is. We screen earlier, screen aggressively. If we can catch it early, we can take care of it.
Thank you.
Dr. Farrington, Mr.
Yes,
Farrington.
sir.
Yes, good evening to each of you. Thank you for this opportunity. I am a 17-year prostate cancer survivor. And I thank you for what this organization is doing to not only deal with awareness, but to deal with the whole spectrum of treatment for prostate cancer. But one of the issues that I think I find as a pastor or the bishop of the church is that this subject matter is not talked about. Prior to my being diagnosed, I had maybe seen 2 or 3 Black men, or heard 2 or 3 Black men talk about their difficulty with prostate. And most of those were advanced, and they, as far as I knew, eventually died of their disease. So when my doctor, Dr. James Bennett, informed me that I had cancer, prostate cancer, I was alarmed. I mean, just literally alarmed and ignorant about what even treatments were available. So I think that that's one of the issues for us, is the conversation piece is often not had. And then it is a very, as you know, very sensitive matter among many men. And so it is a very private matter rather than it becoming a public piece to be talked about and aired in the public. So that's one of the things. Now, the other thing I've heard, this may not be true, that there's incidence of deficiency of vitamin D. That may also be a contributing factor. I don't know, the medical guys or ladies on this forum perhaps can address that, but But that's been one of the things I've been told.
Well, thank you. I think, Bishop, you mentioned that when you were diagnosed with prostate cancer, that you were surprised and kind of alarmed, and you're a 7-year survivor. I'm a 22-year survivor, and I want you to know that when I got that message, I was just like you. I was alarmed, didn't know enough. Clearly, awareness of prostate cancer, I consider one of the biggest issues. Because with the right type of awareness, I think we have a better chance of guiding men towards early detection. But without that awareness, then they don't know about it until they maybe have a symptom. In fact, in my first book that I released in 2001, I had a whole chapter on silence kills because the lack of discussion among men about prostate cancer really kills. And because we have one situation where two brothers had prostate cancer and they didn't know it until they both happened to show up at the doctor at the same time. They just didn't talk about it. So certainly awareness, I think, is a big issue. And that lack of awareness is driving, I believe, lack of early detection. Now, can we get some other members to weigh in on this discussion about some of the key factors driving the disparity?
Tom, this is Milton, and thank you for the opportunity to participate. I routinely go to the doctor. Heightened, I think, by the loss of my wife to breast cancer. It's made me far more vigilant. But I continue to be surprised by the number of guys I know who don't go routinely.
Right.
And so part of it is the fact that that we just don't seem to attend to our health in the way we need to. And when I got the diagnosis, I was as surprised as everybody else. And partly, you know, I work out all the time. I pay attention to what I eat. You know, that there was very little physically that revealed anything. And so, you know, you going around, you doing what you think is supposed to be the right thing, and you feeling good. And so there are, you know, on generally, you know, there aren't the obvious symptoms that
Right.
you got a problem. And I just lost my stepbrother 2 days ago, who's, you know, when the diagnosis was in an advanced state. He had all the signs and still wouldn't go to the doctor. And so you got these extreme behaviors. On the one hand, you've got a problem, but you don't deal with it. And on the other hand, you don't know that you have a problem, but you don't routinely go to the doctor. And that prevents you from getting that diagnosis at an early enough stage that you can do something about it effectively.
My condolences for your stepbrother. I lost my only brother-in-law to prostate cancer. You know, it really always is close at home. I'd also lost my father and both grandfathers, but prostate cancer is all around us. I think the information that Dr. Crawford pointed out, you know, we can talk about prostate cancer in, let's say, in the stratosphere conceptually, but this really comes down to a kind of a personal, you might want to call it a county, a community, a block, a church, and that's really what it comes down to. One of the things that one of the reasons that we focus so much with our disparity rally, with the outreach on the radio and social media, is really to raise awareness. Because with awareness, hopefully we can get men or the women that love them to say, let's talk about early detection. And so that's a big emphasis that we have at PHEN. Let's raise awareness as much as we can. And again, I thank all of you who spoke out with us to raise awareness in Georgia. Now, can I get any other thoughts on this? Dr. Shook, as a urologist, what are you seeing when patients come in? Turn you're muted. You're muted, sir. We're not able to, Jerry, can you do something to help Dr.?
You better?
Yes,
Can you
sir.
hear me now?
Yes.
I kind of picture myself as being a little bit on the front line of seeing those who, irrespective of their race, who are at a possible risk for prostate cancer. As we know, the greatest risk factor is inheritance, and then second to that would be the racial proclivity to have that occur. When I think about it, I don't think it's not that, I don't think it's that the patients, Black patients, as compared to white, I don't think it's that they don't want to come, but as you'd said before, you hit on a number of these issues. One, they may not be aware of that at all. I mean, this is a silent problem, and not until you have late stages of the disease, which is almost mortal, you're not going to know anything about it. They also have to be encouraged. So knowledge, they have to be encouraged by their spouse, or they have to be going to their physician and get a screening, be it with the rectal exam and the PSA, which then sends them to the office. And I have found that almost everybody, and once they're there, if there is a bit of concern, I have a algorithm for following the PSAs if it's modestly elevated, at which time I share with them and say, well, this is about the time we need to go to the next step, which is the ultrasound and biopsy, which then we can get the diagnosis, and then we can do our risk stratification. Low risk obviously would follow, and then the higher, then we would address. So I think that from my perspective, I've had no pushback from any of the patients whatsoever on evaluating and ultimately getting treated. I think it's just getting to that point like this, the awareness, the education, the encouragement. And by doing that, then I think that disparity will decrease, maybe not resolve completely, but I think it would improve.
Now, do you see in your practice when men are initially diagnosed, a big difference in the stage between Black men and white men?
You're talking about the stage
of diagnosis.
The stage in the Gleason grade?
Yes.
Actually not. Now, understand that I'm not a scientist and we don't record it, but I have not noticed it. I think that's probably a better question, or a question better directed to Dr. Terrace, because offhand, my observation has not been that. I mean, that might be a little bit more, but she would know better than I would.
So Dr. Terrace, I'm going to ask you that question.
Yeah, so, it kind of depends on the setting when the patients come to us, right? So I practice both at the VA hospital with Dr. Spearman and at the Medical College of Georgia, and at the VA where, it doesn't matter if you have insurance, it doesn't matter how much money you have, you're going to get screened for all of the diseases. We don't see a big difference stage for stage at time of presentation. All the men that are enrolled in the VA are going to come to the VA for their primary care and get referred to the specialist as needed if they have a slight elevation of their PSA, and get the treatment they need without insurance approvals or delays or copays or things like that that could slow down the process. In contrast, patients that I see that are worried about coming in because of cost that may be referred to me at the Medical College of Georgia from indigent care clinics or things like that, yes, you're absolutely right. They have delayed getting checkups because of financial concerns, because of not having a regular primary care doing those screening tests. And we unfortunately do find more advanced disease when they present for evaluation. That's been shown in research too. If you're in a equal access system, such as the VA or a county system or something like that, you don't see as big of a disparity as you do in the private practice arena.
Now, you did mention cost. How big of a factor do you think cost plays in the disparity?
Well, patients are concerned about it. I know they're concerned about their health too. And I don't think once they find that they've got an abnormality and they need to have something checked, I don't think they spare any expense. They'll manage it at that point. But just getting to a primary care doctor, just like was mentioned before, if they feel fine, they don't feel like anything's wrong with them, why go to the doctor? Spend the money to go to the doctor if they feel fine and everything's great. And it's not until they have other problems and someone checks a PSA that we see them, unfortunately.
I see. Okay. So cost can really drive men, unfortunately, not to come in for screening if they don't have those funds to go to the primary care doctor to have those checkups to get screened, and it could drive them in the late stage.
We'll get them indigent care coverage or something once they have the abnormality.
Right.
Once they have that elevated PSA, we'll get them taken care of. But getting them to have it checked, if they don't want to take the time off work or come up with the copay or whatever they've got to do to be seen when they are feeling fine, is a lot of the problem. I've really enjoyed the fact that we've got a lot of our church congregations represented here. We have tried to do outreach through the local churches, outreach through some of the nurses that belong to those churches that can introduce us to the church leadership in local barbershops. But I'm hoping PHEN can give us some more leads on how we can get the word out to the community.
Well, thank you. And, again, part of what we're going to talk about is how do we collectively collaborate to address these issues. So that's one of the areas that we will work with you on. Dr. Muriel, what are you seeing in the churches? We've done a lot of work with churches over the years. We started our Father's Day rally, as Adrian pointed out, and we started our whole church partnership program in 2009. And we work with hundreds and hundreds of churches across the country. Some churches are really become aggressive and really work close with us. And then, but it takes a whole lot of effort. What are you seeing, Dr. Muriel, from your perspective?
Sure, and thanks for the opportunity to share. One of the things that we have tried to do is to organize information around certain seasons. And so you mentioned Father's Day. Each year we have a men's focus week. And so we make it a point each year for about the last 4 to 5 years during Men's Focus Week to focus on a health component. And for the last 4 or 5 years, it's been prostate health. And so we galvanize a group of men together, which is an intergenerational group. And so it's a group of older men, younger men, it's probably from age range 15 all the way up through about 80 that have conversations around health. Physical health, mental health, emotional health, spiritual health, but there is a component around prostate health. And so we've done that for about 4 or 5 years. Interestingly enough, we had a church member reach out a couple of weeks ago, letting me know that he had recently been diagnosed with prostate cancer, but it was in very early stages. And he had been a part of those conversations. And so I think when we start seeing the success stories of, getting the information, making sure that you get routine checkups. And so, he is one of the ones that we can point to say, the information sessions were effective. And so I think we've got to be more aggressive in the church. I think information gathering, information sharing across generations is important. And then speaking the language too of, I'm a millennial pastor. And so, oftentimes my age group doesn't think that it's important right now. We feel like we can just wait. But, as I've been, becoming more educated around prostate cancer and prostate health, it makes me want to be more aggressive in making sure that I'm taking care of myself and getting checkups regularly. So I think messaging is important, and also focusing on certain times of the year to present certain information.
Thank you. Thank you. And I will point out that we've, with Cascade, we've done work with Cascade over the years. And I mentioned earlier, I know one of your members, Mr. Chapman Carruthers, who's a survivor, is one of my members, and he's been very active with us in Georgia. I will also like to point out is that, you know, the COVID drove a few things. It certainly closed things down, but it forced some of us to find new and better ways to do things. And so for us, we spent a lot of time making sure that we use the virtual capabilities as a way to raise prostate cancer awareness. And so we developed some patient portals that are now available ongoing. So members and men and women can come to our early detection portal and to our treatment portals and really get information. And we're working with churches to really get this information into the hands of their members. And so, Dr. Mira, we're going to look to for your support as we try to spread that out, because we know that we're in a crisis in Georgia. We know that we're in a crisis in this country as it relates to prostate cancer. And raising awareness is key. And we have some tools that can help. Let's see, who would like to add something to this discussion relative to some of the key causes? Now, one of the things I want to move now to, what do we do collectively? I know Dr. Church pointed out she wants to do more with the church community in Augusta. And I know I've talked with the others who wants to do more. I think if I look at the leaders that we brought together in Georgia, we have the ability to make things happen. We have the ability to raise awareness. We not only have the radio programs where we run our message, but we have the messages. So those are evergreen. We can continue to promote those. And we can do a lot of different things together to raise awareness, increase early detection. So who has ideas or thoughts about some of the things that we can do?
Well, Brother Farrington, one of the things that the 100 Black men, both nationally and locally, are doing, and that Brother Oglesby is a president of a chapter as well. Health and wellness is one of our 4 pillars. And so we have consistent programming throughout the year, specifically around health and wellness topics. And I believe that one of the great opportunities that we have, because we are a mentoring organization, and we start as early as the 6th grade, is to break the cultural cycle of, one, Black men not talking to each other. Brother Jones, Milton, Brother Milton Little talked about, sharing, his story. And many of you who are prostate cancer survivors have been compelled to share your story. But typically in the Black community, and particularly Black males of my generation and earlier generations, we don't talk like that. And I think there is still a stigma associated with prostate disease, not because it is a sexual reproduction thing, but because it is part of the sexual organs that adds to the resistance to talk about it, because there's a perception that, well, maybe I'm less than a man, or they may have some perceived shortcomings in terms of manhood. So that's number one. The healthcare system. I spent about 15 years in the managed care side of the business, and this, our system does not invest in preventive care. And so access to care, but also access to health insurance that gives you, additional financial incentives for early detection, for checkups. And I think there's also, I have no evidence to support this, but I grew up in rural North Carolina, and the statistics in Georgia, I'm sure, are probably consistent throughout the South. Yep. But 5 of my 6 uncles on my father's side died of prostate cancer. And I would bet that none of them ever went and got early detection, because probably back then it was the digital rectal exam. And of course, that there was a stigma associated with, having another man or anybody for that matter, go through that. But what we're trying to do within the 100 Black men, particularly through our mentoring, is have these conversations with our mentees, both in high school, college, and then, even within our own organization, and talk about, to your point, the benefits of early detection, and remove that stigma of not going and getting checked up, and whether you have a spouse or another loved one or whatever who are encouraging you to get regular checkups. We are encouraging each other, and hopefully, by talking with our young men and young women as well earlier in their lives, and continuing to repeat this information, it will start to break that cultural cycle.
That's a very good point. We certainly need to do that, and I know we work with 100 Black men in the past, and we want to do what we can right there in Atlanta, and we've talked to Mr. Oglesby about Savannah. In fact, we have some things that, as a result of this rally, that are happening in Savannah next week. So working together with the 100 and looking at hitting it at the right age to make sure men don't learn about their prostate when they're 50. and even you mentioned the young people and the women. I would say it was my wife who forced me to go to the doctor when I was diagnosed with prostate cancer. And so we need to educate the young people, the children, and the women. So we look forward to working with you on that.
So Thomas.
Yes.
So I just wanted to add something. I am the president of the 100 Black Men of Savannah. You saw the statistics, the Georgia statistics, and you saw where Savannah had not less than favorable results. And this meeting is bringing a lot of things to fold for me, because Dr. Shook is actually my urologist, and he does a good job of what he does. But when the president spoke just now about the 100's relationship with disease processes, we mentor across a lifetime. I'm actually a member of the National Health and Wellness team, and I'm actually out of town right now at a conference. And one of our focuses has been cancer awareness. And the local chapter, the Savannah chapter, held a men's health conference about 2 weeks ago, which was fairly well attended. But one of the key things that we did was we invited not only the men for the men conference, but we also invited the wives. But we knew that they would drive the men to get the testing that we were speaking about. And as you can see, during that meeting, the wives were taking notes, and they were asking questions about setting up appointments for the gentlemen to get checked out. So I think part of the key to lessening the disparity and increasing awareness is to do education to decrease folks' level of healthcare illiteracy. We need more people to be healthcare literate, to be able to communicate and to know and to be aware of what's going on with them. And there's several tools that are coming out that we're going to be sharing with folks in our community. We look forward to continuing our collaboration with you all to just do just that, to decrease folks' illiteracy as far as healthcare goes, and to improve their self-ownership of their health, so that we can have more gentlemen that will get checked off in a timely fashion. My day job, I get paid, I manage pulmonary oncology. And we all know that early detection saves whatever cancer you're dealing with. If you can find it early on before it metastasizes or grows, then you're gonna have a much better outcome. And you said that in the statistics that you mentioned from the beginning. So it's gonna be a collaborative effort between PHEN and everybody that's on this call to make that true difference and have folks have a better outcome.
Absolutely, and thank you, and we're certainly up for that. Adrian, do you want to talk about, we had a disparity rally in Jacksonville last year, and one of the The AME Church in the 11th Episcopal District, really, we worked with them and came up with a strategy to reach out to their churches. Adrian, are you there?
Yes, I'm here. Can you hear me?
Yes, I can. Why don't you talk about what we're doing with them?
Well, what we've done over the years is work very closely. One in the AME church with the bishop. We've worked with AMEs and CME, but the AME church in the 11th district. And recently, what PHEN has done, we've looked at how the church would be organized and created a program that's what we call our ambassador program. The ambassador program would include church representative. We have with the Sons of Allen, like in the AME church, they also have a men's program where along with this with the AME church, and that Sons of Allen's group has created one representative who will coordinate all the churches with all the various districts that they may have. And then there will be a representative that will be an ambassador. And those ambassadors will start the educational process through what PHEN provides as educational materials. We've even created an educational portal. And those ambassadors will work with church representatives, which the bishop has laid out in all of the churches in all the district, so that people will begin to be educated on issues of how to share and discuss concerns relative to prostate cancer. One of the things that Mr. Oglesby mentioned, and Thomas, I think is very important to say, is that PHEN, with the disparity rally, we push several websites that we have. When we talk about tools, I think one should know that Mr. Farrington that we have here has created, I think, a tool that the whole world should know about, Tom, was the PHEN Path. This is an educational tool that can be used and you can detect many of the different phases and stages and treatments. I think, Tom, you can address it more than I can, that most people have really loved having that will help on the literacy issue. Our mode now is to get that word out by using the church representation and organization that will help. And we think that the faith houses should have in the men's health area, prostate cancer is the #1 matter here. So there in Florida, all of the churches, according to by district, will be working with our PHEN ambassador program to make sure that we start a complete educational issue with all the PHEN tools and everything we have on our website that goes for them to help families, help men, get that word out and get tested. We've done screenings. We brought everything there, including the plate, the same as we've done with Georgia. Now we're getting ready to march out like soldiers and warriors, because we really do want to attack this disease to help save lives. So I don't, Tom, if that's what you want me to say.
Yeah, I wanted to point that out because we had the disparity rally there last year, but we've done like we have in Georgia. We've been present in Florida for a number of years, and so you know, Keith Milner, you know, and also Oglesby, I can look at the 100 Black Men and say what we're doing with churches is no reason we can't do that with the 100 Black Men. We have the tools, we have the information, we have handouts, all kinds of materials to address early detection, to address treatments, and so we make those available free. We just send a lot of materials down to Savannah to be distributed. So the one thing that we can do is provide the tools and the information to increase awareness and to increase knowledge about treatments. I might point out that I serve with the National Comprehensive Cancer Network. I serve on both their treatment guideline panel and their early detection panel. And on those panels are medical experts. And, you know, I've always tried to provide the patient perspective, but in addition, I have learned a lot listening to these doctors. And so that has allowed us to develop tools that will allow the patients to have enough information to have a good conversation with doctors. And I guess someone is putting that tool up on our treatments tool for our treatment tool. So we have the information, and we are anxious to build on the partnership that we have put together for this disparity rally, and to continue to expand and reach out in our efforts to raise awareness, give men more knowledge about early detection screening, also help them understand about their treatments.
Mr. Farrington, thank you for that, and thank you, Reverend Backus, and the persons who are serving with the 100 Black men. When I was asked to be one of the voices in this piece of broadcasting and making others aware, I was thinking of Juneteenth, which is also Father's Day this year, as a time to launch this in the 6th district where I'm serving the CME church throughout Georgia. And I certainly would love to get that material so I can begin to prepare for that launch. But this is the first anniversary, I believe, nationally, the Juneteenth will be celebrated. And I think it's an ideal time to get our Black churches involved in this movement.
Well, Bishop, I can say that Adrian will be in touch with you, and we will work out what we need to make sure you have information for Juneteenth, and so that you can get the word out, and we'll support that 100%. Let's see. Any other thoughts on? We've had some good thoughts and some good conversation about what we consider to be key factors driving the disparity. We certainly know that awareness is very clear. Lack of awareness is a problem. Early detection is an issue, and also understanding treatments and managing survivorship. You know, I've even heard some survivors, some men who have had surgery, they will tell me, well, I had surgery and I got rid of the problem. I had the prostate taken out, and I don't need to know anything else. I'm through with the disease. Well, number one, early detection of a recurrence is as important as early detection of initial diagnosis. And so getting information out about that is important as well. I don't know, Dr. Teresa, you want to talk about that? The early detection of
yeah, absolutely. You know, I give all of my patients fresh back from surgery or finishing up their radiation a speech about how prostate cancer can come back even 20 years later. And the sooner we catch it coming back, the sooner we can take care of it. There's certainly other opportunities for cure if we catch it early. But many don't follow up. You're right. I haven't had a lot of bad luck with that. Fortunately, most of our patients are coming back, but you do have people that move away, and if someone tells me they're moving, I get them the name of a urologist in the new place, the new state they're moving to or whatever, so they don't get lost. But it's hard sometimes to keep track of folks, which is another plug for the VA, because if they're moving, they're going to another VA. So somebody's going to see what their history is there. But you're right. That's certainly something we need to do. Another comment on outreach. When we do our outreach to community centers and local churches, I take my partner with me, Dr. Sharita King, who is a leader in the Black community here. She went to high school here, still her name's on the wall from being a track star locally, still holds one of the records for the 100-yard dash at UGA. So really sort of a local hero. And went to med school here, got specialty training in sexual functions. So she comes in after I give the scary cancer talk and talks about all the things that she can do to keep men active sexually, maintain their urine control and things like that. So I think that's an important conversation to have. At the same time, you're telling men, that they need to get checked for prostate cancer, because if you catch it early, we have all of these tricks up our sleeves to keep your quality of life normal, which is also a big part of survivorship.
Thank you. Thank you. Any other inputs from the panelists? Now, I want to open the floor up for any questions that the audience may have. I want to thank you for staying with us, audience. So, what are your questions?
I had one question, Tom.
Okay.
I have relatives in Georgia, and the question, especially those people who are self-pay, once you're diagnosed or once you have an elevation in your PSA, and how do you move from having an elevated PSA to finding resource to help pay for your biopsy, or pay for in this case that newer technologies where they're using PSMA PET to look for to expand upon where the disease is in your body. So you can be diagnosed, but then what do you do if you don't lack the resources to get the appropriate additional treatment and care?
I can handle it from at least my institution's perspective, which is a large proportion of indigent care or self-pay, you would call them. And once you get the diagnosis of cancer, if you're below a certain earning line, you qualify for Medicare just from having that diagnosis. And Medicare can be billed retroactively. So we can, the cost of the biopsy and the PSAs, we could go back and bill them. So you don't have to worry about that once the diagnosis is made. So that's a possibility. Of course, the person, and I'm sure you've heard stories of people who their PSA was elevated, their first biopsy didn't show anything. We got an MRI, we biopsied them again. And, those bills start to rack up. And our hospital has a very reasonable payment plan they can sign up for, but it does discourage some people. You're right. But we have a social worker in our cancer clinic to help with things like that, because it's a problem. And we don't want anyone to not get care just because they're worried about the bill.
Thank you. I have, I see something here on the chat. The question is how a DRE exam can show a normal prostate, which is what my urologist told me in November and May 22, but my PSA went from 4.9 to 5.8, and I have symptoms. So that's a good question. Dr. Tersh, you want to address that question about how can a DRE exam show a normal prostate?
So the surface of the prostate that's in contact with the rectum is a small percentage of the prostate. And the PSA is much more sensitive. So only about 3% of cancers are actually picked up on a rectal exam with a normal PSA. We don't start feeling anything abnormal on rectal exam till the PSA really gets high a lot of times. So what you're describing is actually the most common scenario when the patient has a normal digital rectal exam, but a high and rising PSA. So I'd recommend that you have a prostate biopsy. You may want to get an MRI first. If depending on your age, you may want to repeat the PSA again for men over 75. We know that that level of PSA is probably a very small cancer. Men over 75, 80% of them will have a few cells of prostate cancer in their prostate that may not be life-threatening. But if you're 55, this is a scary scenario. So you need to have some more studies done.
Thank you. Are there any other questions? We don't see any other questions. Okay. One of the things then I will move towards kind of summarizing our meeting tonight and say, again, I want to thank those panelists and leaders who've joined us tonight and who joined us in recorded messages to raise awareness, and say that I look at this as a beginning, and we certainly will look forward to working with you and expanding our partnership in Georgia. I think we all have a common objective, and that is to reduce the disparity, to save lives, and to get the word out. So we look forward to working with you to do just that. So we will be in touch with you with kind of a summary of where we are and next steps. And I would like to say to the audience who joined us this evening, thank you for joining us. And I do hope that you learn. I want to suggest that you go to our website if you're interested in information about early detection, treatments, or managing survivorship. Go to rapcancer.org. That's RAP Cancer. That's for Rally Against Prostate Cancer, rapcancer.org. And so we are excited to be moving forward in Georgia. We know there's a crisis in Georgia, but Georgia is not alone. And we will work together to address the crisis at hand. Thank you all for being with us this evening, our panelists, and thank the audience. And again, I want to thank our sponsors. With that, I am going to say good night.